Hey, good morning. Welcome everybody to the MIN-ADAM Study Year 2020 data release. We're very excited to have you here today, and I'm going to turn it over to Dr. Jennifer Hall-Lande to get us started.
Thank you, Libby, and welcome everyone to our Study Year 2020 data release. It is so nice to have you here. And if you're here, we want to say thank you for all of the support you've given our project. We have our data partners here, we have our LEN fellows and other supporters of the MIN-ADAM project, and we're happy to have you here today. We are releasing our Minnesota data today, but the CDC is also releasing their broader numbers that look at select communities in the United States. I believe the embargo is lifting as we speak. So you will be the first audience for the Minnesota data today. So it is exciting. Next slide, please. Just a couple of pieces here. Today we are going to release to you both the CDC broader network numbers today and also a broad overview of Minnesota prevalence numbers. We're considering today part 1, and we will have another opportunity to share part 2, which will be our autism prevalence rates across select communities. Next slide. Couple of things to share first before we begin. A note about language today. This is public health data, and our public health research often comes from a medical model context. Because it comes from this framework, you may hear words like disorder and disability. Please know that our team values the importance of the work being done on acceptance, understanding, and inclusion. This is a collaborative project across the Department of Pediatrics, School of Public Health, and it sits in the Institute on Community Integration within the College of Education and Human Development. So we are bringing together multiple departments, multiple perspectives and disciplines, and we're all sharing together. Couple other things. We are aware that within the field of autism, there's identity first and person first language. What we know or what we hear that the autistic community suggests identity first. So we may use the term autistic. Other individuals prefer person first language. So we also use terms such as persons with autism. Our intention is to be respectful and not ableist. And we are aware of the impact of language we use in our work. Language is important, and we'll continue to work on not using ableist language as much as possible. Next slide. All right, so for those of you that have been here before, some of this is going to look familiar, but some of you may be new. So I'm going to give a little background on the ADAM network, and not to devolve into acronyms, but many of you are aware. ADAM is shorthand for the Autism and Developmental Disabilities Monitoring Network. I'm going to here on out refer to it as ADAM. I know many of you know that, but I just want to make sure you know what I'm talking about. But there's many, many important aspects about the ADAM project. It is the largest ongoing tracking system for autism in the United States. The tracking with the ADAM network, that is a CDC-sponsored project, started back in 2000. I'm going to show you a slide a little later. But we talk a lot about the overall prevalence numbers within ADAM, but it offers a lot of rich information. Really, I think ADAM has made many significant contributions in helping us understand not only the prevalence, but also characteristics. We understand better what the population of children with autism look like in the US communities that ADAM is monitoring in. It also compares how autism looks in different parts of the United States. It provides valuable information on the age of identification, and it identifies trends over time, since they've been collecting data for now over 20 years. You know, and on a side note, I think many of us use ADAM in our work. I'm in the autism literature a lot. One of the first lines in a lot of autism research papers are the ADAM prevalence statistics. When people talk or advocate with policymakers, they talk about these numbers. These numbers are readily used, and it's something we really appreciate and celebrate that we have this in our states. Next slide. So here is a map showing the ADDM network. And I always get a few surprises in the audience that ADDM is not in every state. It's in 11 sites, and you're seeing here. And speaking of language, I'm going to call myself out in the beginning. We really have to be careful with our language around autism prevalence or autism surveillance, in that since we're not in every state, we're not in every community. I often use the term national as shorthand, but really it's most appropriate to say within select communities in the United States. So here's what we're seeing with the 11 communities. The purple communities, you see Minnesota is purple on this map. We track autism prevalence rates in 4 and 8-year-olds. And then you see the blue on the map, our neighbor Wisconsin tracks 4, 8, and 16-year-olds. So again, this is not in every community in the United States. It's a select group of states, and that is something that often is a surprise. And so it certainly is a limitation of our data. There are many, many strengths, but we want to be upfront. And I may use the term national and slip, but we know it is a select number of states. And even more specific, if we look at those states, and next is the heat map, we look within these 11 sites, it's not the whole state. What we see is a trend of the autism prevalence work clustered around highly or densely populated urban areas. You see, we are in the Twin Cities area. What you see is the graph, the ADDM tracking area within Minnesota. We look over at Wisconsin, the Milwaukee area is included. So we see these clusters around urban areas. We need to do that so that we get a robust denominator, that we have the capacity within that to work in these areas. We would love to go statewide, but right now we're centered within our state in the Twin Cities area. So that's also something interesting. And while we also have to be careful, again, while ADDM has many strengths, we are not in the whole state and we aren't in the whole country. And we just wanted to be transparent about that. Next slide. So just sort of a brief overview about our approach or methodology. We are doing active case finding, and we are looking for documentation in children's records, documentation of 3 primary components of data: a written autism medical diagnosis by a qualified professional, a special education classification or eligibility of autism, that's where our schools come in, or an ASD ICD code obtained from administrative or billing information. So that is sort of at the core of our active case finding. Our graphic to the right just sort of delineates it. It's a bit oversimplified, but I think it's helpful in imagining. Step 1, sites identify places in the community that educate, diagnose, treat, and provide services to children with autism. And what you're seeing there is we're showing both clinics and education sites. A strength of the ADDM methodology is we go to where kids are. We aren't looking just in clinics. We're looking in clinics and schools. Combining the two, we get to most of the kids that are served in that area under an autism case definition. We're really proud that we're in the schools and we have robust participation. Many of you are on the call today. Thank you so much in helping us to get the data we need to report these numbers. Step 2, our abstractors who are on this. Thank you, abstractors. They review records and collect diagnostic and eligibility data. Scientists such as our epidemiologist, Dr. Ruby Nguyen, analyze the information as well as the CDC epidemiologists. And step 4 is what we're doing today. We return the results to the community and talk about how this is reflective of our systems and how we can improve and plan and support communities. Really, community is the key. We consider all of you part of our community supporting ADDM, and we hope we're providing you valuable data for your systems. Next slide. Again, many of you have seen this before, but we're going to talk a lot today about prevalence. This is a basic prevalence formula. We talk about 8-year-olds and 4-year-olds, but for a while, ADDM was only looking at 8-year-olds. When ADDM started, they identified 8-year-olds as likely the area of peak prevalence was as young as they could go. So they identified 8-year-olds as young as they could go and still have a robust number of kids with autism. You know, if we did it today, we would probably go younger, but we are looking at 4-year-olds. But not to belabor the point, the prevalence formula is simple. So the numerator here, we have number of 8-year-olds with autism on the top, and then the denominator is total number of 8-year-olds within that area. We use census tract data. That's our denominator, the total number, and that gives us our prevalence as defined in this project. So we'll talk a lot about that today. Next slide. So our first question of interest on this project, what is the prevalence of 8-year-old children? And I should say, today I am going to present the broader, the national, and we know national means the select communities within the ADM network. I'm going to talk about the CDC data, and Dr. Amy Esler is going to share the Minnesota data. So you're going to have to wait a little bit for that, but the exciting part is that is just being released right now nationally. So you're going to be one of the first to hear it. So we answer that question. That's sort of our, first and foundational question. Next slide. So what we are seeing with the broader ADM data in the United States, we are seeing a prevalence number of 1 in 36 8-year-old children were identified with autism within the ADM network. That, if you think of that about in terms of percentages, it's about 2.8%. I always pivot to this, but one thing it tells us is autism is no longer a low incidence disability. If you think of an average 3rd grade class, we're going to assume based on these numbers, there's likely at least one child with autism in the class. And that helps us understand how do we plan for services and supports for children. Next slide. So here is a bit of history for those of you that care, but this is the history now that I've told you the overall prevalence number from the CDC, just a little walk back in history. The CDC started collecting this data in study year 2000, and this is a great place for me to share that we are talking about study year 2000. We're not talking about 2023. We are March 23rd, 2023 today, but we're looking back at our study year 2020, and that was the pandemic year. So we'll talk about that a little more later. But if we look across time, first year was the year 2000, and we were seeing rates of 1 in 150. And we're seeing a steady trend. One thing I have to caution you, and I like to be very transparent about limitations. The communities that were measured did vary across these. So we're not really comparing apples to apples, but if we're interested in seeing the general trend over time with the ADM study, it is interesting, but certainly sites changed, communities changed. In 2018, the methodology changed. So there are definitely several caveats, but as you see this, we see a steady trend of estimates that are higher year after year with a little stabilization when we saw the 1 in 68 to this year with the 1 in 36. Next slide. Again, this is a bar chart. I have some caveats, but it's the percentage of 8-year-old children identified with autism by ADM network sites. You see these are all the ADM network sites. And if we look at this, we see the overall, what I shared before, about 2.8%. We're seeing California is the highest in the network and significantly high in terms of their prevalence rates. Following California is our state of Minnesota. One thing I want to caution you is, while it looks like we're second in the network, and if you look at it ordinally, yes, but these distinctions between this group, Arizona, Tennessee, Wisconsin, New Jersey, Minnesota, it's really very small. And if we look at confidence intervals, a lot of them are overlapping. And so they're likely not significantly different, but this is, for what it's worth, what it looks like across the network. The real outlier is California, which with much higher rates. Next slide. This slide is interesting. It's a little busy, so bear with me, but it has some very interesting data. So we're looking at that same bar graph that I showed you previously, showing the ordering. And it looks at the contributions of the sites. So if you can think back to our methodology slide, we collect in 3 areas. So if you look at the purple here, this had an autism ICD code only. If you look at the blue, this is our schools. These are the educational eligibility in autism without diagnosis. That is blue. And then the green is an ASD in autism clinical diagnosis. So as we look at that, we see that Minnesota does stand out. in that a significant percentage of our autism cases of children with autism are coming from the schools. And to me, this highlights the significant contribution we have in Minnesota of our schools in identifying and serving kids with autism. I think it is a good thing, but within the network, we really had the highest percentage within schools. And again, I really think that is a positive thing, that our schools do a good job of identifying and serving children with autism and their families. Next slide. This is one we get a lot of questions about. This is our slide talking about sex distribution within autism, and we're comparing males and females. I want to share a caveat that the way we collect this data is sex that is stated in their record. This may not represent a child's gender identity. So if that's a question you have, we are just going right off the record and as it says. So certainly it's limited. But what we're seeing in terms of the ADDM network national data, as males were 3.8 times more likely to be identified with autism than females. This has been a pretty robust statistic over time. We see it within the ADDM data. We see it in other prevalence studies. But one hopeful trend is this was the first time that the number of females was 1%. And so that is an improvement. We have a long ways to go, but that, and certainly the ratio went a little below 4. So slowly but surely, likely not fast enough, but we are seeing some gains in that area. We still have a long way to go. Next slide. Another interesting piece that ADDM has contributed is how the population has changed over time. Long ago, we used to view autism as commonly having a co-occurring intellectual disability. We viewed it in the past, perhaps as children with high support needs. We know now that we have a different distribution in the landscape as we look at prevalence. So if you look at this pie chart here, this is our intelligence quote. It's among children with autism who had IQ scores available. I do want to say, as a psychologist, I understand that a diagnosis of intellectual disability involves more than IQ, but this is the proxy measure, the CDC network, they use IQ. We're not including sort of the full, including adaptive and others. But anyway, what we're seeing here and what's important, we're seeing that within the sample, the broader ADDM sample, 37.9% had an IQ less than or equal to 70. So that would be our group that we would consider having an intellectual disability. So the majority of the population of children identified with autism within the ADDM network had an IQ of 70 or above. That has definite implications for services, supports, future programming as they move throughout the lifespan. I find that to be a very interesting data point. Next slide. Something else interesting about the broader ADDM network data, it was the first time that the percentage of that we were seeing estimated prevalence by race and ethnicity, that we saw children from non-white communities or from culturally linguistically diverse communities, their rates were higher. If we look at this whisker plot, we're seeing white here is in the yellow orange, and we're seeing Asian, Pacific Islander, Hispanic, Black. What we look for is, do those bars cross? And they did not. We were seeing significantly higher rates in the Asian, Pacific Islander, Hispanic, and Black communities than we were seeing in the white community. That has been an interesting point of discussion within the CDC, the broader CDC network, because this used to be flipped. We'd like to think we are making progress in early identification. We are doing a better job of serving children that live in culturally and linguistically diverse communities. We still have a long ways to go, but it is interesting to see these numbers change over time. Next slide. Another, while we can celebrate a lot, or certainly hopeful cautiously, that we're perhaps closing some of the gaps around autism identification, some other areas we're still seeing some significant disparities. So as we look at the percent of children 8 years with autism with co-occurring intellectual disability by sex, race, and ethnicity, we take a look at this male to female, and we are seeing a statistically significant difference for females versus males in terms of the co-occurring intellectual disability. Also, we are seeing significance in that we're seeing a higher rate of co-occurring intellectual disability and autism in our Black community. And then also as we look at the Asian community compared to white. So this is an area we are seeing a disparity, and we need to continue to look at these numbers, understand them better. One additional piece we need to consider, are we not doing a good job of identifying kids without intellectual disabilities in our Black community and our Asian communities? We need to think about that as well, because all of that goes into this data. Next slide. Okay, so then our second part has been the addition to ADDM. What is the prevalence of autism for 4-year-old children? So I'm going to share a little bit about those numbers as well. Okay, so here is the distribution that we talked about before. This is among 4-year-olds. And we're seeing once again, California is leading the pack if we look at these the network data. And within this ordering, Minnesota is falling much farther down. Yet we're still seeing this strong contribution from our schools in identifying kids within the broader network. It's just interesting to see again that within Minnesota, what a strong contributor the schools are to our overall identification landscape. We're going to talk a little more about California likely at a later time. But again, they are also identifying a significant number of 4-year-olds. I'm going to share those numbers in just a second. Next slide. So the broader ADDM findings, what they were seeing from the study year 2020 was a rate of identifying 4-year-olds 1 in 46, or 2.2 would be the average percentage identified with autism. This did go down from the 2020 numbers, which is hopeful. I'm sorry, we are identifying more. I said that reverse. We are identifying more. This number, this prevalence number is a little higher in our 4-year-olds this time around, which is interesting, especially given the COVID pandemic. Next slide. So this is a slide we have mixed feelings about because we collect data on median age of identification, and it's been a point of interest to communities. When are we identifying children with autism? We know from the autism literature that the sooner we get to children, the better their life outcomes. That is a sound finding. The better their developmental outcomes. There's some research that says it's better for the family. And so we want to get that age young. We also know that with proper training, a trained clinician can identify a child with autism anywhere between 18 months and 24 months. But as we track this data, the age of autism clinical diagnosis nationally is 49 months, or 4 years, 1 month. So that's significantly later than what is optimal. And then when we include clinical and special education eligibility, we're seeing 52 months, or 4 years, 3 months. It's interesting as we track these numbers, they've been relatively stable over time. They've been resistant to change. And therefore, we're actually looking at calculating these numbers differently and looking more at cumulative incidence. And Dr. Esler is going to share some slides on that because there are some hopeful signs in terms of us getting to kids earlier. This is a number we watch, but it has its limitations. And of the children identified with autism, about 49% had an evaluation recorded by age 36 months. Next slide. Again, and this is what our 4-year-olds look like in terms of prevalence of autism in children 4 years old by race and ethnicity. Again, and this one, and these are census tract data. So we're using the terms that census uses. We're seeing the highest rate in Hispanic, followed by Black, followed by Asian or Pacific Islander, and white is the prevalence is lower again. So that's an interesting trend we continue to see. Next slide. So one of your questions would be, what were the impacts of COVID-19? Again, because this is study year 2020, we have a great opportunity to share information on how the pandemic influenced evaluation identification rates. So these again are the broader ADDM network numbers. Next slide. I know this slide is a little busy, but COVID impacts difference in number of developmental evaluations and incidence of autism identification per 1,000 children. I know there's a lot on this slide, but if you take a look, you'll see this is looking at evaluations, comparing evaluations in the study years 2016 through 2020 to the previous study years of 2012 to 2016. And if you look at the first slide, number of evaluations nationally, we're seeing an upward trend as we look through these years. Right at where you see the red lines start here, we see March 2020, when the pandemic started, we're seeing a significant decrease in number of evaluations. We then see it start to pick back up again, but clearly this is, a nice illustration of the impact on number of evaluations, which we then know in turn is going to affect the incidence of autism. And when we're seeing the identification of autism, we're seeing the same trend. Obviously, these are interrelated constructs of, again, a significant decline during the pandemic years. It will be interesting to see how we bounce back when we report next time, but certainly as we look to early identification and we know best practices that get to kids early, these are concerning numbers. Next slide. And with that, I'm going to pivot to Dr. Amy Esler, the co-PI on ADDM, and she is going to share the findings in Minnesota.
Thank you. Yes. So here we go. Just to provide a little bit of history before we launch into the data. One of the reasons that the University of Minnesota is in the ADDM network is because of community advocacy and, our initial research in this area rose out of parent reports of high numbers of Somali children attending preschool programs for children with autism. And so this grassroots effort from parents, community members, and some providers really advocated at the federal level for Minnesota to be looked at more closely. So first, the Minnesota Department of Health devoted funds and looked at prevalence, just looking at educational data, prevalence in preschools in the mid-2000s. And from that information, there were some years when Somali children did attend preschool programs at higher rates and a couple of years where they didn't, and it fluctuated a lot from year to year. But that grassroots effort and this initial data from MDH really sparked us to be able to work with the NIH, the CDC, Autism Speaks to do a study of prevalence within Minneapolis from 2011 to 2013. And that study, we looked at all of our racial and ethnic groups, but we're particularly interested in Somali children. And we found that Somali children and white children did not differ in their prevalence. However, we did find unexpectedly low rates of autism in Asian and Hmong children and Native American children. One disparity we did find was that a very high rate, 100% of the Somali children who had IQ data in their records had co-occurring intellectual disability, suggesting greater support needs than other groups. So this led to us joining the formal CDC ADDM network in 2015, and we've been refunded twice now, where we've continued to study these trends. And, subsequent years, and some of you might remember this, we've had varying findings with regard to prevalence of autism and co-occurrence of intellectual disability for Somali children and other groups. We're currently analyzing our 2020 data, and we'll release that with updated findings in the near future. Our goals in Minnesota, again, were to estimate autism prevalence for 4- and 8-year-olds in our geographic area and to look at characteristics like prevalence across race, ethnicity, across sex, and the presence of co-occurring intellectual disability. We also want to share our findings like we are today to improve services and supports for children with autism and in their communities. Our geographic area, so the area in which we collected data, were parts of Hennepin, Ramsey, and Anoka counties, including our biggest cities of St. Paul and Minneapolis. We included the race and ethnicity data that are categories, that are tracked by the CDC, and again in the near future we'll present separately on Somali and our Asian groups here. Okay, so starting with prevalence for 8-year-old children in Minnesota, this was what our denominator or our population looked like in the geographic area that was included. So all of the kids represented in our data were 16,150 8-year-olds. And this is the race ethnicity breakdown in the area that we looked at. So we had quite a diverse population included, with about 42% white non-Hispanic, 23% Black non-Hispanic, 16% Asian, about 11% Hispanic. 2 or more races is a new category that the CDC added this year. So we tracked that as well, and American Indian. Our prevalence among 8-year-olds this year was 1 in 34, or about 3%. So that's similar to the overall ADAM network rate of 1 in 36. And actually our rate in 2018 was 1 in 36. So we're about an 8% increase in prevalence since 2018 overall. And then we also looked at the broad race ethnicity categories tracked by the CDC. And what's important to take away from this group is we did find higher prevalence this year among Hispanic children compared to white children. So about 1.3 times the rate there. And that was statistically significant. One caution we would note here is that while we know statistically it is a higher rate, we do have some groups with pretty small numbers. So I think overall in Minnesota, we identified 482 children with autism in our geographic area. And so within some of these groups, that number gets smaller and smaller when we're talking about just the kids identified with autism. So here's what we found, but take it with a grain of salt, because we have small groups in some categories here. You can also see the precision by looking at the 95% confidence interval. So this confidence interval tells you that 90% of the time, the autism prevalence would fall within this range. And so we have some ranges that are pretty wide. So for 2 or more races, the true prevalence falls somewhere between 22.1 and 43.2. That's a pretty wide estimate. Overall, that's our largest group here, so the estimate is a little bit more narrow. So think about that too as you're comparing these numbers. In Minnesota, our male-female ratio was similar, maybe a teeny bit higher than the overall network, but very similar to past estimates. We had 4.3 times more males than females. And if you break down their prevalence, it's 1 in 21 for males, 1 in 91 for females. I do want to note that we track sex based on what's documented in the record. So we don't really know how well this maps onto different people who might have a different gender identity than what's documented in the records. So just want to make sure that's understood. And for co-occurring intellectual disability, we were very similar to other states in the network. We had, 86% of our kids had IQ data available in their records, and 32% had an IQ equal to or under 70, which is how the ADAM network defines intellectual disability. Our median age at clinical diagnosis was 4 years, 11 months. Unfortunately, that is the latest age of diagnosis across the ADAM network. It is a little bit younger than 2018, where I think we were over 5 years as our median age of diagnosis, but it's still much later than we'd like. If we include special education eligibility as an identification, then it goes down to 4 years, 8 months. And only 42% of our kids that we identified had had an evaluation, and that means any kind of evaluation for developmental concerns by age 36 months. And then we can look at our 4-year-old data. So our geographic area contained 16,326 kids, 4-year-olds, I should say, and similar racial and ethnic breakdown as our 8-year-olds. And prevalence among 4-year-olds actually fell from 2018. It's now, we found this year, 1 in 53, whereas in 2018 it was 1 in 44. Or, today it's 1.9%. That's about an 18% decrease. Similar male-female ratio of 4.1 times more males than females. So the male prevalence was 1 in 34 and the female prevalence was 1 in 137. And here's our breakdown by race and ethnicity. So among 4-year-olds, we saw some differences in prevalence across race and ethnicity. We saw that Black children had a higher prevalence than white children. Asian children also had a higher prevalence than white children, as did Hispanic children. Same caveats here about the data. We want to look at these confidence intervals to get an understanding of how precise these estimates are. Our groups, our racial and ethnic groups with larger numbers of children are going to have a more precise estimate than some of our smaller groups. So you can see the confidence interval for Hispanic children is quite wide. But nonetheless, statistically, their prevalence was higher than white. A few slides ago, we mentioned that Minnesota had the latest median age of diagnosis across the sites. This slide offers a slightly different perspective and maybe some hope that our early identification efforts are effective. These graphs show cumulative incidence, and what that means is the rate of identification over time. So the rate of new cases identified over time. And Minnesota, like the addm network as a whole, showed the trend we want to see, which is that 4-year-olds had a higher rate of identification than 8-year-olds, meaning there's more identification happening in the younger group than the older age group. So looking at 4-year-olds, they were identified at 1.5 times the rate of 8-year-olds. So we've got a larger bolus of identification happening at young ages. However, we are continuing to identify kids, late, all the way up to age 8 represented in this data. And I know clinically, I continue to identify kids, people, even into adulthood. So that impacts median age. But some good growth in this area. And here's the Minnesota COVID-19 impact. So this chart is showing you the change in incidence or new identifications of autism by month. And what we see is when the pandemic hit, where this dotted line is, in March 2020, like all of the other states, we saw a drop in identification, a drop in new cases identified. We saw a blip of recovery in June 2020, but then continued to show lower identification through the end of the year. Now, we stopped collecting data at the end of December 2020, so we're not sure what this looks like now, but Minnesota was one of 3 states in the network that did not show some recovery back to, positive increases in identification by the end of the year. Okay. Future research needs to look at what factors might have contributed to a sustained reduction in identification in Minnesota compared to other states. There may be differences across states in terms of returning to in-person learning, when clinics open back up to in-person testing, and then even differences in when the pandemic hit. So, we in Minnesota had another increase in community rates of COVID in fall, and maybe other states didn't have that same impact. So this is areas for us to investigate in the coming years. I want to talk about limitations of our data. The geographic area in 2020, one really important factor to know is that we had, so when we were looking at 2018 data, that was in 2020. So we were smack in the middle of the pandemic, and it was more difficult to access records because places were closed, or they were really, closed to visitors coming in who didn't need to be there. And schools were, really under stress. So were healthcare organizations switching over to virtual learning and virtual clinic visits. So we had a smaller number of school districts and a smaller number of people represented in our data in 2018. 2020, a lot of that came back. So we had, we went from about 10,000 kids that we were including in 2018 to now 16,000. So when we're comparing prevalence rates from 2020 to 2018, just remember that the kids included in the geographic areas and the school districts included did differ. And that could be accounting for some of our changes in prevalence and, perhaps our lower prevalence in for 4-year-olds in 2020. The findings in the report overall reflect a small number of children concentrated in a large metropolitan area, and it may not generalize to other parts of the state or to other subpopulations across the state. We did find varying prevalence rates across racial and ethnic groups in Minnesota. For the first time, white children had significantly lower prevalence rates than other racial and ethnic groups in the 8-year-old group, and again in the 4-year-old group. Another limitation is that we continue to have small numbers of American Indian, Alaska Native children identified within our geographic area. So we have, once again, did not identify enough cases of autism within the American Indian community to be able to include them in our analyses. And while our trends and prevalence rates have been changing a little bit, we continue to see a persistent pattern of higher percentages of Black children with intellectual disability compared to other groups within the addm network. We will be looking at those trends in our Minnesota data in the coming months as well. Where we do find differences, it's important to focus on general health disparities that might influence these differences. I think that's probably the most important takeaway, is how do we best serve and support kids. Also want to reiterate again that we have not yet looked at our Somali population. We're in the process of doing that, and we look forward to sharing those data with you in the coming months. And finally, in Minnesota, we identify autism much later than we should and later than other states. So even though autism can be identified really at 18 to 24 months for a lot of kids, and even though we know parents are bringing concerns about their children's development at 18 to 24 months, the median age of diagnosis is still pretty close to 5 years. So that's concerning given all that we know about the importance of early intervention. All right, I'm going to turn it back over to Dr. Hall-Lande, who's going to talk about next steps.
Thank you, Dr. Esler. I really appreciated your walk through the Minnesota data. So thank you so much. Well, I get to talk about the fun parts, the next steps. Right now, we are starting on study year 2022. We have our abstractors out in the field. Thank you, school districts. And we're starting to monitor 4-year-olds and 8-year-olds. And I have some breaking news. We were just added to the 16-year-olds. And I'm going to talk a little more about that, but our team is very excited to take a look at autism in adolescence. And I'm going to share a little more about that later. And then, as Dr. Esler said, we'll continue on the prevalence and characteristics and co-occurring conditions among specific communities in Minnesota. We'll be reporting on that's yet to come, but we're also continuing to look at that as well. Next slide. A little more about the 16-year-olds. Some of the things we're going to be looking at and collecting information on, characteristics associated with later autism identification. Just like Dr. Esler said, one of the things about our delayed age of identification, we also identify kids later. So all of that's going in. And I am curious, what does it look like for kids? What is the trajectory like for kids that are or adolescents that are identified later? We're going to take a look at complex educational and healthcare needs, transition issues. We'll be able to look back in records and see movement through the system all the way from childhood and adolescence. And then an improved understanding of supports and planning needed during the adolescent years. We are very excited to start looking into that data. So that is a big next step for our team. Next slide. And again, the implications and use of the data, we talk about it a lot in ADM, but as those of us that work in the field who are researchers, it's always, is the work you do making an impact in communities? Because really that's what matters. We don't want our research to sit on a dusty shelf or whatever the modern day equivalent is, I guess, like me, saved on my desktop and not read. We want it out in the community and used. And we want it to be a tool for supporting systems in terms of planning, but also a tool for advocacy and understanding. A couple other things with what we sort of apply our ADM data, we want to improve our early identification. We know from all of this data that we need to build our workforce capacity. I'm going to talk about this a little later. And I guess finally, sort of another takeaway, another implication of what we're sharing today, and I say it every year that we report this, these children were 8 in 2020, and it's 2-3 years later. So they're 11, they're 12, they're heading into adolescence. We're going to start collecting data on what that looks like, but do we really know how to support this population? Do we know, in light of some of the data around characteristics around autism and co-occurring intellectual disability and those that have IQs above 7, what do we know that we can apply to our learning and really make the experience and the supports we provide more valuable to adolescents and then finally to adults? We know that we have a lot of teenagers or young adults entering the adult service system, and we still have a long ways to go to, one, have the capacity, the workforce capacity, and the programming that supports their needs. So next slide. Again, I think everybody's talking about workforce. How can we build our workforce? What are we doing to build our workforce? We know there are workforce and provider shortages at almost every level within the field of autism. We have shortages in terms of assessment, diagnosis, and treatment. And we've talked about waiting lists. I'm going to talk a little more about that. We really need to expand our training and recruitment and retention of professionals and direct support workers with targeted recruitment of professionals and training them from culturally and linguistically diverse communities, as well as building capacity across disciplines. Next slide. I'm going to talk a little bit about how we're going to do the workforce piece. This is hot off the presses, right? The data has just been released on a national front from CDC. This is now public. If you enjoyed this presentation, you can delve deeper and look at the ADM community report. Also, the eating of ice cream, it looks like summer. We can be hopeful that is coming. But this gives a state-by-state profile if you're interested in what autism looks like within other states in the network, as well as a lot of the overall ADM network findings. I find it to be a very useful tool. I encourage you to check. This should be up online and accessible now. Next slide. Our ADM website, please check. We'll be updating the numbers as well. So both check at a national level. That's where you can get the community report as well as our MIN ADM website. Next slide. And just to talk a little bit about, because we do get questions as researchers, so you're talking to us about prevalence. What are you doing? What are you doing to address some of these issues around early identification and workforce capacity? How is your research making a difference? I'm going to profile a few, not all of the things we're doing in the autism space that engage the community and are trying to work to build some of these capacities. Next slide. One of which is our partnership between ADM and Act Early. Actorly is the outreach arm of ADDM. It conducts outreach and shares information with the community. Today, we're talking to the community, we're talking about the data, and we're sharing resources. I encourage everyone to Google Learn the Signs Actorly. Take a look at their website. There is a host of free materials that talk about healthy developmental monitoring and early signs of autism and how to get help and how to get support if you're seeing developmental delays. It really is how we're out in communities. Next slide. Here's my colleague, Andrea Castillo, who does a lot of work in our wonderful partnership with Help Me Grow Minnesota, where we're out where families are and communities are, and we're sharing Help Me Grow materials, we're sharing Actorly materials, and helping to support early identification and helping to really empower families and communities to understand child development and to get help and supports if needed. Another summer picture, we can be hopeful. Next slide, it does exist. A few of our tools, some of you may have heard, we revised our tools with Learn the Signs Actorly this year. And we found that when you do that with something that people like, you get a lot of feedback, both good and also some feedback for improvement. But please take a look at the materials. Again, we have just a wealth of free resources that we want used to help families track development, help childcare providers, healthcare providers. Next slide. We can just keep moving. These are those developmental screening sheets. I want to leave time for question. And if you check out one resource, previous slide, Amy, our milestone tracker app. That is a wonderful tool for families you upload the child's age. I have a pretend child in mine named Betty Rose, and I follow her development because I don't have little children at home. And it gives developmental milestones. It prepares you for well-child visits. It gives discussion points if you have concerns about development. It gives developmentally appropriate activities. Families love it. We have it in English and Spanish. And if it's one tool I can share, it is this one because it really puts power in the hands, literally on their cell phones, of families to understand and intervene and get supports if needed. Next slide. Some of the work we did around COVID impacts on Minnesota early childhood systems, our partners across systems, many of whom are here today. We looked more deeply at how COVID was impacting systems that serve early childhood, young children and families, and saw significant impacts across systems. This isn't ADDM data. We did include some, but we included from other systems like childcare and education and healthcare and immunizations. If you look at our ICI website, this report is online, and it really is an interdisciplinary approach to how COVID impacted our early education systems and our early childhood systems. Next slide. I'm just keeping an eye on time. We have a study here that Dr. Esler and I are both on, Autism First, Bridging Barriers to Intervention Access for Waitlisted Children. We know there's a significant number on children on wait lists, and we know that delays age of identification. If you're waiting on a wait list, you aren't getting into services. Not only is this study providing early intervention, but it's working with families who are waitlisted, some of whom are getting assessments and supports through this study. 100, we're hoping to serve up to 100 families. We understand that's just a small dent, but it's a way we feel we're helping work through some of these waitlist issues. Next slide. Here's our Minnesota LEN program. Several of the LEN fellows are here today. Welcome. LEN stands for Leadership, Education, and Neurodevelopmental Disabilities, Minnesota LEN. We are looking to train the next generation of leaders to build the workforce in autism and developmental disabilities. We have fellows from multiple disciplines, including developmental, behavioral pediatrics, and occupational therapy, social work, education. There is a whole list. I think it's up to 13, but they learn together, and we are growing our capacity, many of whom are leaders out in their community. We're very proud of this program. We train about 30 to 35 a year. And at this point, I think we were hoping to get up to 300 this year. We may be a little below that, but each year we are working, and then we have broader impact in communities as we go out and train more medium-term fellows. But this is a picture, I love it, of our LEN trainees. Next slide. We have several teams here led by Dr. Rachel Freeman and Dr. Jessica Simasek, giving back positive behavior supports the community. Please check out this website, Minnesota Positive Supports website. Another way that we're working with state agencies and doing positive behavior supports within the community. Just another resource we're sharing. Next slide. I'm going to keep moving at a good clip here. Another project we have is to look at physical health and mental health with adults and adolescents with autism. That's a project that I lead. ARP is what it stands for. I'm currently, if you go to the next slide, working on a project with one of our Len fellows, former Len fellows, about loneliness and isolation and community engagement and results. He in fact is presenting at Ph.D. Research Day right now on this work, and we're hoping to expand it even more. Next slide.
I'm just wondering if we want to skip to acknowledgements so that people have time to put some questions in the
Absolutely,
Q&A.
absolutely. Yep. Okay, so acknowledgements and thank yous. Thank you to all of you here today. We couldn't do this work without the support of the community. We get support from our funder, CDC, but our state agencies have been supportive. Our Minnesota Department of Health, Minnesota Department of Education, Department of Human Services, DEED, and of course, our educational and clinic partners. We thank you. The project couldn't work without you, and your contribution is valuable. Here's our MinAdam team. Not everyone's picture, not everyone gave a picture, but you can take a look. And Amy, one last thing I promised I would promote, if you can go a few slides back, to an upcoming autism symposium as well. That is, many of us are part of the Autism Interagency, and we are hosting it. I said I would promote this. We work together across agencies and disciplines to provide services, supports, improve services, work together. And there'll be a symposium where I, again, will present on some of these prevalence data on April 12th. Okay, we will go to the end. So thank you. We appreciate your time. We appreciate you being here. Thank you for all your contributions. Thank you to the addm staff. You're hearing Dr. Esler and I present. We're the face of this today, but really the majority of the work happens from our wonderful team. And we so appreciate all the work, and we appreciate our data partners, school districts, state agencies, as well as clinics. I do see one question. I can start with this one, and I can start, and then feel free to type your questions in. Our first question is, given that this year was the first year of data collection that happened during the pandemic, is there any comment on the impact of the pandemic, not on increased prevalence, but on challenges with the methodology? That's a great question. I'll start, and I'll let Dr. Esler weigh in. As we look at the addm methodology, it's definitely a case study in strengths and limitations. Any way you collect data is going to have these strengths and limitations. There really is no perfect methodology, but we do feel we do a good job in terms of being comprehensive, being in both schools and clinics, doing active case finding. But to your points, the methods rely on the availability of records, the quality and completeness. We are taking those at face value, and we don't have a lot of control over that. And certainly the pandemic amplified it, right? And so as we look at the addm network data, the broader network data, we see that many sites actually lost access, for example, to some of their special education records. So we certainly know that impacted what they were able to collect. And yes, the trend we are seeing as well is looking at big administrative data sets. That's one outside of our methodology, but to get a more representative sample, for example, linking into Medicaid and broader educational data sets, or other ways we can get it, for example, the whole state of Minnesota or a broader group of kids without going in and doing active case finding. That's not something we're doing actively right now, but there are some ways to sort of circumvent that. And certainly the pandemic, again, really highlighted some of the challenges with this active case finding. Dr. Esler, do you want to share any more with that?
No, I mean, I think the impact was really maybe felt a little bit more in 2018 because we were collecting data in 2018. In 2020, when access was a little bit harder. We have another question that just came in. Do you think that school districts no longer labeling evaluating a student for ASD categorical identification prior to kindergarten entry, turning 7, et cetera, keeping them DD is part of the late identification data, and how to encourage districts to identify early with that label. Thank you for that question, Cindy. I think that is something that is a statewide initiative, right? To really encourage school districts to identify autism when it's autism and not wait until age 7. It's important for parents to have that accurate information to be able to seek other services in the community that would be helpful to their child. I'm mindful that it is after 1 o'clock, so quick answer to the other part of this question is that yes, we do think that it could have been differences in the number of school districts included between 2018 and 2020, and policies across school districts on when they identify autism, because we are looking at that formal identification. So that can impact prevalence numbers and also age of identification for sure.
Thank you so much for your questions. Thank you, Dr. Esler, for answering those quickly. Thank you, everyone, for being here today. Thank you for your ongoing support of ADDM. And we are here. Please check out our website. Check out the CDC national website. The data is released. If you look on some of the major autism organizational websites, you will see it released. But we really appreciate your time today and your contributions and support to ADDM. Thank you so much, and we will see you next time. Bye-bye.